Carrie Anders, who's a professor of medicine and the medical director of the Brain and Spine Metastasis Center at Duke University. Dr. Anders received her medical degree at the Brody School of Medicine in East Carolina, and did her internal residency and oncology residency at Duke, where she is right now. So she is a true North Carolinian. And so Dr. Anders' ultimate research goal is to uncover the genetic and genomic understandings of breast cancer brain metastasis. And she's been a recipient of many awards to further her research from the NCI, the American Society for Cancer Clinical Oncology, and Duke University. So Carrie, the floor is all yours.
Thank you so much, Josh, for this opportunity to speak. This has been a great lecture series to date. And it's just so exciting to see what is happening on the preclinical side of things. The insights are fantastic. And as a medical oncologist, I could not agree more. We are seeing our patients younger and younger with brain metastasis, and we need to figure this out for them. So I'm going to take a bit of a pivot and move from the bench to the bedside. The topic that I am going to be covering is the current and future trials for breast cancer brain metastasis. Just a brief disclosure slide. So just to kind of overview what we'll talk about over the next 20 minutes, I think this team has already done a fantastic job of defining breast cancer brain metastasis. I will provide a little historical context of where things were when I started my career from a clinical trials perspective, and then also where we're going in the future. I also just wanted to provide some updates on our current treatment options, because there's been so much movement in this field, both from the local therapy or radiation surgical side of things, and in the systemic therapy side of things. And then really kind of leave with some questions about what we believe the next generation of clinical trials should look like for our patients with breast cancer and brain metastasis. So as many of the prior speakers have said, brain metastasis are becoming a more common problem in advanced cancer. And I know the topic today is breast cancer, but we are seeing this across all of our solid tumor types. We believe that this is because we're doing better at treating our patients' extracranial disease. They're living longer, and we're seeing brain metastasis in diseases we never saw before. I think it remains that our top 3 histologies or cancer types that are associated with brain metastasis are lung cancer, melanoma, and of course, breast cancer. And we do see in our breast cancer population that patients who have HER2 positive disease and those who lack expression, whose tumors lack expression of estrogen, progesterone, and HER2 have the highest risk of brain metastasis during their metastatic journey. So what do we see in the clinic? How do our patients present? We don't have presently guidelines to routinely perform brain MRIs for every patient with breast cancer who walks through the door. And if I had a tool that would help me predict who would develop brain metastasis and ways that I could act on that, I would be so thrilled. So I think that's something we need to be working toward as a research community. When we do have patients, particularly patients with advanced disease, coming to our clinics and we're talking with them about their symptoms since our prior visit, we really try to focus even on subtle changes, word finding challenges. I've had a young patient of mine present with brain metastasis on an MRI just based on changes in her handwriting. Common things that we see based on the brain as the area of metastasis include headache, nausea, changes with muscular strength, and then in extreme cases, we do see seizures and the consequences of increased intracranial pressure. So it's important to think about this in our clinics for all medical oncologists across the disease spectrum, and particularly in the breast cancer space for those who have advanced triple negative disease and HER2 positive disease. And I'm hopeful that we will see the time where we have genomic predictors to help us know when we should be doing routine brain MRIs, because I do believe learning about this earlier in a patient's disease course will improve their outcome. And even better, to echo Dr. Stieg, how could we actually prevent, both from a secondary prevention, but particularly from a primary prevention perspective. So here is our roadmap for local therapy and brain metastasis and decades of research on how we should best deliver radiation therapy to the brain. When I think about this, I think about patients who are presenting with a solitary brain lesion or one brain metastasis, a limited number. And I would say this number starts at 2 and ends at 10 plus. And we're seeing that number rise every year in terms of which patients can receive radiosurgery. And then all the way on the right-hand side of the slide are patients who present with multiple lesions. So we approach each of these different clinical scenarios differently. And we do have data that if a patient presents with a solitary lesion, there is survival advantage for resecting that lesion and then following resection with radiosurgery. If resection is not feasible, i.e. the location could cause side effects that would be intolerable or would leave the patient with neurologic compromise, we do move forward with radiosurgery to that area. And that's not surgery in terms of taking the patient to the operating room, but in fact using very high doses of radiation in a very defined location. And in the center, if a patient presents with 2 or greater brain metastasis, we rely on radiosurgery. And the advantage of this approach is that we can target the lesions themselves in hopes of sparing normal brain. But as Dr. Stieg pointed out, this also leads to brain that's not protected by radiation. And this is where systemic therapies can come in a smart manner to prevent additional lesions in the brain. And then for patients who present with multiple lesions or multiple small lesions throughout the brain, we rely on whole brain radiation therapy, which is typically 10 days of radiation therapy that bathes the entire brain with a low dose of radiation. Because our patients are living longer, which is wonderful, we don't want them to have the longer term sequela of whole brain radiation therapy, including trouble with neurocognition. And so there are techniques to spare our memory center, which is the hippocampus, and to prescribe protective medications such as memantine during whole brain radiation therapy to improve neurocognitive outcomes. So moving forward to the clinical trials space, I wanted to just take a historical perspective to the past. And when I say the past, that's not that distant. I would say 10 to 15 years ago. And when I was in my training and fellowship, and one of the reasons that I elected to move into brain metastasis as my area of research is that I was quite frustrated by the fact that many of our young patients were recurring in the brain. And one of the first inclusion criteria on our clinical trial templates was history of brain metastasis. And so that was limiting, novel emerging therapies only to patients without brain metastasis. And I think we've seen a significant improvement in this paradigm over the past decade. And now we're in the present where we're seeing trials, and we'll talk about some of these trials designed specifically for patients with brain metastasis. And this is endorsed by many of our governing bodies, including the NCI and the American Society of Clinical Oncology. So I'm very happy to see this movement forward. So as a practicing medical oncologist, and when I consider what I have in my toolkit for patients with brain metastasis, we typically go to the NCCN, which is the National Comprehensive Cancer Network, which really combines all of the late-breaking data into a distilled version for practicing medical oncologists. And when we're approaching systemic therapy options for patients with brain metastasis, we largely think about them in 2 main buckets. including those that are HER2 positive versus those that are HER2 negative, here listed as non-specific. And we'll talk about many of these therapies, but largely in the HER2 positive space, we have a plethora of tyrosine kinase inhibitors. So basically blocking the machinery inside the cells, targeting HER2, in combination with chemotherapies that we know cross the blood-brain barrier, namely capecitabine. And then in some cases, in combination with trastuzumab, which is an antibody against HER2, which historically has not passed the blood-brain barrier as effectively. I will say the newest therapy, and we'll go through this data in more detail, is tucatinib, and this was added to the list in the spring of this year in 2020. In the HER2 negative space, you'll largely see chemotherapy here, and this is a space that we really need to be doing better in, and an area of active research of our teams and many others. We have the platinums, and then we'll also talk about the CDK4/6 inhibitors for patients whose brain metastasis are estrogen receptor positive and HER2 negative. So moving forward in the HER2 positive space, this is really just another view of the therapies that we've just discussed, but the ones that I really want to focus in on today are the newer kids on the block. So the tucatinib compound, which was defined through the HER2CLIMB study that was mentioned earlier, as well as a novel antibody drug conjugate called trastuzumab deruxtecan. So tucatinib, as I spoke of, is a small molecule inhibitor that targets the tyrosine kinase intracellular machinery of a HER2 positive cell. And one of the uniquities of tucatinib compared to the earlier generation tyrosine kinase inhibitors is that it is very specific for HER2 and does not hit another target called HER1 or EGFR, epithelial growth factor receptor. And what this does is it really limits the toxicity to patients, where we do see GI toxicity and rash in particular when we target EGFR with the neratinib and lapatinib compound. In the laboratory, HER2 positive breast cancer brain metastasis mouse models were evaluated to each of these three therapies, and you can see in the, trying to see the color here, oops. In the tucatinib arm, also, or the green, previously known as ONT380, the best survival of that animal model, which then led into the phase 1 experience of capecitabine. We talked about this being a brain permeable chemotherapeutic with the HER2-directed antibody trastuzumab and the tyrosine kinase inhibitor tucatinib. And what was interesting in the early phase experience is that we saw beautiful responses, 61% in the extracranial disease space. But what was also quite interesting, knowing that this drug crossed the blood-brain barrier, the central nervous system or brain metastasis response rate was also quite respectable at 42%. And just to give some historical perspective, in the past, kind of our gold standard of lapatinib with capecitabine, response rates were around half at about 20%. So this moved forward to the design of a phase 3 randomized placebo-controlled study called HER2CLIMB. And this was a study of over 600 patients, all with metastatic HER2 positive breast cancer. And one of the very unique aspects of this study, sort of thinking about where we were 10 to 15 years ago, where patients with brain metastasis were not enrolled or were excluded from these studies, patients with brain metastasis were enrolled in this study and actually made up close to 50% of the patient population. The patients were randomized in a 2-to-1 fashion to tucatinib trastuzumab capecitabine versus placebo trastuzumab capecitabine. And here are the results that we learned about last December. We did learn that the HER2CLIMB primary analysis, which included all the patients, those with and without brain metastasis, not only had an improvement in progression-free survival, or the time before a patient's disease became refractory to that therapy, that risk of progression was reduced by almost half. The other thing that we learned, and importantly, is that the risk of death was reduced by a third for the addition of tucatinib to the capecitabine and trastuzumab. The patients on the tucatinib arm were living longer. And what I don't show in this slide deck, but was the toxicity profile. And while we did see some GI toxicity, it was much less than previous generations of therapy. And then when the group of patients who were enrolled with brain metastasis, so 291 of the 612 patients, there was also a significant reduction in progression of death by 50%. So this was very exciting and led to the FDA approval of the triplet combination, which we're using routinely in our clinic today. So I think this is a beautiful story of really a bench to bedside for a patient population who clearly is in need of approved available therapies. And I'm just thrilled to be able to have this therapy at my fingertips in my clinic for my patients who present with brain metastasis. So moving forward with an antibody drug conjugate. So this is trastuzumab deruxtecan. And essentially what you'll see here on the slide, on the left-hand side of the slide, you'll see an antibody, just like antibodies against viruses, but this one is targeting HER2. And it's linked to chemotherapeutic, which has a mechanism of a topoisomerase inhibitor, so essentially interferes with DNA, it induces DNA damage. And what's interesting about this particular compound is for every molecule of trastuzumab, there are actually 8 moieties of chemotherapy, or 8 different chemotherapies or payloads, so a very potent payload. If we tried to give that degree of chemotherapy directly into the vein, it would not be tolerated. So this is essentially a Trojan horse effect, where the trastuzumab binds the cancer cell and delivers this very toxic payload directly to the tumor cells, sparing the patient the toxicities. So this compound was evaluated in a series of studies and is ongoing as well, called the Destiny studies. And we learned about it initially in the Destiny Breast 01 study. Essentially, this was a study of over 250 patients who had advanced HER2 positive breast cancer, who were treated with several different doses, which was deemed, the final dose was deemed 5.4 milligrams per kilogram. But what was also interesting here is that patients with stable treated brain metastasis were allowed. So we're seeing that theme. So essentially, this slide shows that almost every single patient enrolled in this study had reduction in their tumor. So all of this is called a waterfall plot. All of the blue lines represent reduction in tumor by a certain percentage. And for those who had reduction over 30%, what we would call a confirmed overall response, this was 60%. And then I took this text directly from the New England Journal of Medicine paper to just show the magnitude and the duration of response to this therapy in patients with brain metastasis. So essentially, what I want you to take home from this is that the patients who had brain metastasis at enrollment did actually even a little better than the patients who did not have brain metastasis. They were free of disease progression for 18 months, a year and a half, before having to move to another therapy. The other thing to note about this patient population is they'd received 6 prior lines of therapy, so a really unprecedented progression-free survival. So very excited about this compound. So I want to be cognizant of time, but also wanted to just briefly talk about systemic therapy for HER2 negative breast cancer brain metastasis. And as I said earlier, this is a space where I'm hopeful to see more development in the coming years. Whereas we do have FDA approval of tucatinib in patients with brain metastasis and the trastuzumab deruxtecan across metastatic breast cancer, we don't have any FDA approved therapy specifically for patients with HER2 negative breast cancer brain metastasis to date. But I did want to focus in on one compound called abemaciclib. This is essentially a small molecule that blocks cell cycling, which is seen in our cancer cells, And it is specifically approved for patients who have estrogen receptor positive HER2 negative metastatic breast cancer. One of the things that we learned about preclinically is that this compound crosses the blood-brain barrier. And we were lucky enough to be part of a study called JPBO, which investigated the activity of abemaciclib in patients who had HER2 negative, but hormone receptor positive metastatic breast cancer to brain. And we did see that many patients benefited from that therapy, and we use this routinely in our clinics. And when I am selecting a CDK4/6 inhibitor from the group that we have of 3 in my patients with brain metastasis, this is my first choice. So Dr. Stieg also talked about Priscilla Bastianis's work at Mass General, and she shed a significant light into the biology of brain metastasis across all histologies. And this is just an example of one of her set of data showing alterations in the CDK pathway, the target of abemaciclib, in over 50% of the brain metastasis, which could potentially predict sensitivity to a CDK4/6 inhibitor. And in fact, this has been translated to the design of a clinical trial that is enrolling nationwide. So this is essentially a match type study where patients who've had a craniotomy or a brain surgery for standard of care purposes could have their brain metastasis tissue tested for alterations in the CDK pathway, the PI3 kinase pathway, or the NTRK ROS1 pathway. And if that alteration is found in the brain metastasis, they would be assigned to the appropriate treatment arm with brain permeable compounds that target the alteration. So as we look toward the future, and I know I've given a lot of information here, there's still many remaining questions. I did not touch on immunotherapy in my talk, others have, but I think one of the questions is, how will immunotherapy impact our patients with brain metastasis? Many of our solid tumor types have an immunotherapy indication. So now we need to see how are both the extracranial disease compartments and the intracranial disease compartments responding, and how might it differ in the brain microenvironment, just as we've heard of earlier today. There's a lot of emphasis on who should go first. Should it be the radiation oncologist or should it be the medical oncologist? And are there benefits to sequencing radiation therapy before immunotherapy or vice versa? We're also looking at combination therapies for brain metastasis. So in the setting of HER2 positive disease, should we be combining tucatinib with other therapies in the HER2 positive space? And in fact, there's an ongoing study of an antibody drug conjugate called TDM1 with or without tucatinib. And then also the concept of a window of opportunity study. So that is evaluating a therapy or a systemic therapy, drug therapy prior to a resection of a tumor for standard of care purposes to see how much drug is actually getting into the brain metastasis to complement much of the work that we've seen in our animal models, and many, many more. So with that, I'll close. I really appreciate the opportunity to speak to you today. There is so much to discuss in this space, and I'm very happy to see where we are, a decade plus later, and only am even more excited to see where we'll be a decade down the road with all of the exciting preclinical data we've seen for translation. So thank you, Dr. Niemann, for the opportunity to speak. Look forward to Q&A.
Thank you, Dr. Anders. It was great to hear all the progress. And I know that this is a big concern for patients, about wanting more clinical trials and brain mets, and that certainly has changed over the landscape of years. And I know that you have been a huge advocate of this. So I know everyone has been, very appreciative of the push that you've been doing.